Irene, registered nurse with Confluence Health, and I'm with the Population Health Case Management Department and under the Transition Care Management team. So I probably met some of you when some of you were out at the contact center in Wenatchee training with Sheila and Katie, and I might have trained a few of you too. Yeah, I'll be helping out with the presentation. And
my name's Kobe Towers, and I'm a primary care coding educator here at Confluence Health. So basically my job is to educate the providers on their documentation and coding. But I also provide support to the coding staff as well. Some of you may have received emails from me in the past because if you're AAPC members, because I was the president of our chapter for a while.
So I think I will just kind of start out here, and some of this may be on the front end, maybe a little bit of a review, but we went through all the questions that we got forwarded from John that you all had submitted. So we kind of tried to integrate a lot of those questions into the presentation, I think, and then some of them we'll talk about that you might not see in there, and then there's a time at the end for questions for sure, but you can always stop us mid-presentation if you have a question that's pertinent to something in there. So essentially, some of this was covered in the training, but the coding people might not have been there, so it might give them a better understanding. But for my role as a transition care management nurse with Confluence Health, this is the kind of current program we use. But so as a TCM nurse, we get our discharge list from one of our unit clerks, and we kind of go through that list and we see who we're going to call for the day. So essentially, you can see on the slide here, it shows that you can perform these TCM calls or services from discharges from all these facilities that you see up there, like acute care hospitals, psychiatric hospitals, skilled nursing, long-term care, inpatient rehab. I would keep in mind you can call observation patients because that's kind of key, because in the rural areas at smaller hospitals you might have a tendency to have more observation patients than admitted, maybe. I'm not sure. But and you can also call, it says, partial hospitalization at community mental health center. One of the key things though is, while you could perform TCM calls, follow-up calls from a lot of these facilities, you would have to get the documentation within a timely manner to be able to do that. So unless you have a system set up with these facilities or a process, you might not be able to get it in time if you don't have an established relationship with one of those facilities. But so essentially, the top is the list of, if they're discharged from this place, you can call. The bottom list is, these people, they must either be discharged home, to assisted living, to an adult family home. The big thing is you can't call if they're discharged from the hospital to a skilled nursing and expect to perform the TCM service. But those are the places where they have to go home to, essentially, to be able to qualify for the call. So I would assume some of you all have kind of set up your transition care management kind of template for the questions you'll ask. And this is the one we currently use at Confluence Health that I think we showed people when they were down in Wenatchee training. But I would, if you haven't set up your template already, you can always use this template or create your own, but just make sure you need to have, on your TCM call, you should have the date of discharge, and make sure you do the MedRec is going to be very key. Also important is going to be their follow-up care, because some of those things, as you'll see later, kind of have to be documented to be able to bill, or are important for certain sections of the TCM. But and so I would just if you're going to create something, look at what's required and do that work ahead of time so you don't have to keep changing it. But that is what we currently use for our template. Time frames are where docs and providers get their eyes start to kind of glaze over. And I know when we did provider education, it seems like that's the point where they might have just kind of given up because they have a lot on their plate and it's one more thing. And it is kind of easy to remember after you've done it a million times, but the gist of this whole thing is if a patient's discharged from the hospital and they have a follow-up appointment within 2 business days of discharge, that's 2 business days, not complete days, so holidays and weekends don't count. You can still bill for this higher TCM charge, which Kobe can talk about later, as long as they do have that follow-up appointment within 2 business days. So at Confluence, depending on how much staffing we have, we may or may not call those people if they have that appointment within 2 business days. If we're well staffed, we will try to reach them. If not, we'll skip them. And also key is you can bill for this if you make at least 2 attempts to reach the patient within that 2 business day period. Keep in mind a little bit later, there's a little, there should be an asterisk next to that. We'll point it out on the PowerPoint because in theory you're supposed to continually try to reach that person, although you never really will. Usually if you've made a couple attempts, typically you're not going to reach them after that. But yeah, and down here it says day 1 of these 2 days begins the day after discharge. So if the patient was discharged on a Friday, you would have until the end of Tuesday to reach them. One important thing later on, and sorry, this is a lot of kind of days and different things to throw at you, but the provider either has to see this patient for a follow-up visit within 7 days if you're going to bill for a high complexity, and that's 7 straight days, not business days. If it's a moderate complexity, which will be explained later, it has to be within 14 calendar days, not business days. So that's one kind of key thing to remember. Let's see. So within 2 days, this is kind of there's 3 components of a TCM call. So the first one is the interactive contact, or what kind of we're doing as a TCM nurse. So as you can read, it's within 2 business days, you must make an interactive contact with the patient and or their caregiver by telephone, email, or face-to-face. I don't know of anyone that does it any other way but phone, but I suppose it could be, and my knowledge of this outside of our areas is not vast, so maybe they are doing it via email or another way. Yeah. You essentially, we're going to follow all of the kind of cues in our TCM template and go through our telephone call. But down below that, it talks about the CMS guidelines about how if you do make those 2 attempts and you can't reach them, you can still bill. But as you can see, they do say continue your attempts to reach this patient until they are successful. And that's required, I guess, to bill for the TCM services. But we here we just make the 2 attempts typically. If we have time permitting, we'll make another attempt. So essentially, just think of part 1 back here is the TCM call, the TCM template. That's what we're reviewing. The call also carries into part 2 in a way. And so part of billing for transition care management is providing some non-face-to-face services also. So they talk about the provider here furnishing non-face-to-face services, and I can have a list here. But just keep in mind, clinical staff under the, provider direction can provide certain non-face-to-face services. So the doc is going to provide a lot of these in the office visit that happens down the road. So here's a list of, some of the non-face-to-face services. The doc will probably should document that they, I think it would help probably to back up that they're doing these non-face-to-face services. If they documented that they reviewed the discharge summary, that could take care of that one right off the bat. But often in their notes they'll talk about reviewing labs, and they would take care of another one. I don't know that there's a certain number of these that you have to have that I'm aware of, and Kobe's saying no. So the doc probably should be, reviewing at least one of these pieces of information.
So can I ask? Mm-hmm. This is Sean, just jumping in. So if you do a call and they do a non-face-to-face service, does that count as a billable feature? Or am I?
No, this is all included in the TCM services.
Okay.
Yeah, this would all be part of part of this non-face-to-face would be in the doc's note, and then part of it would be in the TCM note, from my understanding.
Yeah.
All is part of the TCM billable service.
That's why the RVUs, I hate to talk about RVUs, but that's why the RVUs are so much higher, both the work RVUs for the provider and the total RVUs for the facility, because it includes all the non-face-to-face stuff that's done for the patient. All that stuff we've not been paid for in the past.
So they're pretty broad as far as these non-face-to-face services that that the docs can do and providers. But here, you'll see clinical staff under supervision from provider, based on state laws, can provide some of these services. What I typically think of here for the TCM call, for the nurses doing the TCM call, MedRec's probably the one that always comes to mind for me, because we, as you'll see later, MedRec has to be done at some point post-discharge, either in the TCM call or the doc's office visit. So as a TCM nurse, we always try to do it at the TCM call, as long as there's not some barrier to doing that. But you have the list there. You cover quite a bit of these in the basic TCM call. So there's a lot of patient education that goes along, and so that would be kind of the second line down there. They talk about education to the patient, family, guardian, caretaker. Often you'll talk about ADLs, but where the MedRec would probably fall is assess and support treatment adherence and medication management. We always, if they did referrals to agencies, that would of course, you'd be talking about community and health resources there as noted on the PowerPoint. This is kind of seems like some of the soft stuff you do. These guidelines, they seem fairly vague, but when you do your documentation, make note that you're talking about these things or that you reviewed referrals or things like that, because it helps back up the documentation and the work that you're doing. So if you're discussing referrals, I would document it so that you can get credit for it. So think of the first two as part of the TCM call. Part of that second part, the non-face-to-face, is in the doc's note. So this third part is the doc's or provider's face-to-face visit. And this is where the provider has the face-to-face visit with the patient within the time frames that you'll see, and then they'll use one of the two current CPT codes for billing for TCM services. It mentions any other visits provided during the 30-day TCM time period will be billed as an EM service, which Cody can probably explain.
An office visit,
okay.
A regular office visit.
So here is
where I take over.
Yeah, this is probably where Kobe takes over, and I'll kind of jump in here as I can help out.
So now we'll talk about the coding part. So the two codes for TCM are the 99495, which the patient has to be seen within 14 calendar days versus business days. And the documentation has to meet moderate complexity decision-making, at least moderate complexity. The other code, 99496, the visit has to be within 7 calendar days, and the documentation has to meet high complexity decision-making. It's kind of hard to get through to some providers that just because they see them in 7 days, it does not mean they get to build a high complexity code. So what we've gone to telling our providers is think of it in terms as your regular office visits. If you would normally bill a 99214 for that visit, then you're going to bill the 99495. If you would bill a 99215 for that visit, then you would go with the 99496, because those have similar complexity requirements. So documentation from the provider has to include the discharge date, the interactive contact date, so the date the TCM call was made, or the attempted dates. MedRec has to be documented. The face-to-face visit date, which hopefully it's on your note. Your EMR is going to put the data service on there. And then the medical complexity or decision-making, whether it's moderate or high. We do encourage our providers to always document their history or exam to support at least a level 4 visit, because for the payers that don't pay for TCM, we want to be able to change these to an E&M or office visit so we can still get paid. Oh, back here, for all the stuff that's required in the documentation, the CMS stuff always says it has to be in the medical record. And we actually sent a question to Noridian asking them to clarify medical record versus in that note for that day. And we couldn't get a straight answer of them. They just quoted CMS basically back to us that it says it has to be in the medical record. So we encourage our docs to put all this stuff in their notes, so that way we just have our bases covered. So for those of you that are not coders and don't recognize this stuff here, this is a tool that was created by Marshfield Clinic to put a point system to how medical complexity is determined when you're auditing out a service. So in box A there is the number of problems. Box B is your table of risk, and then box C is the data reviewed. I'm not going to go into big detail about how you determine all that, but this is how complexity of a visit is scored and determined.
And I think the PowerPoint would be available too, right?
Yeah, if you have an attachment of that, that would be good.
Yeah. This is just what it looks like on our sheet. Most places have their own sheets. It all is very similar. So our workflow here. So the charge session is dropped to the coder's work queue when the provider inputs their charge. So the first thing the coders do is they confirm who the payer is and if it's a payer that pays for TCM services. If not, they go ahead and change the visit to an E&M. We do not send it back to the provider to do that because they have enough on their plates already. We go ahead and change it based on their documentation. The coder reviews the chart to make sure that the TCM contact was made within 2 business days or that the patient is seen within that 2 business days if that phone call is not made. And this is an important step because sometimes those patients, when Joel was talking about the fact they don't call those patients that they see are scheduled within 2 business days, sometimes those patients reschedule. And so if that interactive contact did not take place, we again then cannot bill the TCM code, so the coder would have to change it to an E&M versus the TCM code.
So it might, at Confluence we kind of switched how we do it, but it might, if the if your organization is not going to call them if they have the appointment within 2 business days, and still intends to bill for it, it might behoove the nurse or whoever is doing the TCM call to have a system where they check up to make sure the patient made it to the visit. And if they didn't, you know, they could call the patient or make the attempts to reach the patient within the 2 business days.
The coder then reviews the provider's documentation to make sure all the required elements are there, the discharge date. They make sure that med rec was either done by the TCM nurse or by the provider and documented. They check to make sure it's all there, and once they're done with that, then they go ahead and defer the charge for 30 days. So when these first became billable, Medicare said you had to defer them for 30 days and bill them on that 30th day. But it wasn't very long until they came back and said, no, you can go ahead and submit them on the date of the face-to-face visit. However, we chose to continue the workflow of holding them for 30 days because there's certain circumstances where you can't bill the TCM, such as if the patient expires during that 30 days, you cannot bill the TCM. So it's less work for us if we hold the charge versus if we have to go back and correct it after the fact. So after that 30 days, the coder then confirms to make sure the patient has not expired or they have not been readmitted to the hospital. Because if they're readmitted within that 30 days, we have to change it to an E&M and start the whole TCM process over again. When they get discharged this next time, a new phone call has to be made. However, there's one exception to that. If the patient's readmitted towards the end of the 30 days and they're discharged from that new inpatient stay after that initial 30-day TCM service is up, we can bill a new TCM when they're discharged that second time. The coder confirms that all the diagnosis codes that the provider has used are correct, and they make sure that all HCC opportunities are captured. Because some of these patients that end up in the hospital are ones that don't want to come in for their primary care visits, and this is an opportunity to capture those things that we don't get to capture on a regular basis, like their lower extremity amputations or their status of having an ostomy. You know, those highly rated diagnosis codes that get missed often. And then at that 30-day mark, the charge is submitted to the insurance, and the date that's on it is the date of the face-to-face visit. Any questions on that? I know that was a lot for one slide.
So can I confirm, so if you go through this whole process and they get readmitted, you can't get paid?
You change it to an E&M.
You change it to an EMM,
Yeah.
but you, by technicality, you don't get paid for doing the TCM service.
Correct.
Okay.
Yeah. You're going to just change it to a regular office visit code.
What about the subsequent discharge from the hospital then? It falls under what you're talking about with the...
If they get discharged after that first 30 days, then you get to bill that first TCM, and then you get to start over with another TCM. Sorry, I just want to make sure. All right. What'd you do?
I'll try it.
Oh, there we go. So the insurance plans that reimburse for TCM: Medicare, Medicare Advantage plans, Premera, Aetna, United Health, TRICARE and TriWest. If it's one of the plans that requires a prior authorization, you have to have a prior auth. Indian Health, of course, follows CMS, so as long as you have a PO, Indian Health should cover it. And then the payers that don't reimburse, surprisingly, are DSHS, Ambetter, Molina Marketplace, all of the Healthy Option plans, and LNI.
Can you go back to that last slide, please?
Sure. This one?
Yes.
Are you gonna, oh, you're gonna send out the slides so they'll have this right.
Yeah, Sean, I will send this out. One of the questions I have standing, because and you might get to this again, knowing that all of our organizations are rural health clinics that are on the phone. Does that impact their ability to reimburse these insurers?
So with the rural health clinics, we only get paid our all-inclusive rate. We do not get paid the TCM rates. But as an organization, we made the decision to go ahead and bill these codes because it's taking care of our patients. You know, you're doing that interactive phone call. It's enticing, you know, it's incentivizing the providers to see the patients post-discharge. I know that's horrible to say, but I mean, they're getting paid on their RVUs, so they're getting the higher RVUs, but we're getting the patients in and taken care of. And hopefully we're seeing a reduction in readmissions. I don't have those numbers, but does that answer your question?
Yeah, so by technicality, you can't bill any of these insurers as a rural health clinic for TCM.
No, we do bill all these payers.
Do they pay for TCM, or do they pay all-inclusive? If you're a
Medicare
rural
and
health clinic.
Medicare Advantage pay the all-inclusive.
Okay.
The commercial payers pay the TCM rate. They don't pay the all-inclusive rate. So for the commercial payers, you get the higher reimbursement. Sorry, I wasn't picking up what you were putting down.
And I'm not a coder, I will make that, or TCM person by training, so if that question makes sense and anyone can say it better, or if you felt like I didn't ask the right question, feel free to ask on the phone.
Yeah, so the rural health rules only apply to Medicare and DSHS.
Okay.
So for your commercial payers, you get whatever their allowable is based on your contract.
Would you be able to explain, like, how, even if they can't bill in the rural health, how capturing those codes increases the revenue for the following year?
With the HCC, using it as an opportunity to capture those HCC diagnosis codes, then increases your patient's RAP score, so that you see that reimbursement next year. From the Medicare Advantage plans, from the, you know, even though the Healthy Options plans don't pay for the actual 99495 and 99496 doing these visits, and capturing those diagnosis codes for those plans that are paying based on severity, it's just a great opportunity to do that. And a lot of these patients come out of the hospital with new severity rated diagnosis codes.
Does that, I'm sorry, because I think
That's
this
okay.
is important. Does that make sense to everyone on the phone, or does that spur any new questions?
Because I think my understanding, if they get more of those codes, then their reimbursement overall will be more the next year.
Yeah.
If they're, okay, yeah. Because they'll have more of these codes and a higher level of care possibly needed, so. In the long run, it might not benefit some providers, but long term, or in the short term, it won't benefit them, but the long run, it would definitely benefit them.
Right. I like interactive discussion, so you guys please don't be afraid to ask questions and tell me if I'm saying something wrong or that doesn't make sense. So Joel put in here some links to CMS documents, and then I think we're done and ready for questions. So now you guys do have to talk.
So I'm going to ask, go ahead, Vicki.
This is Vicki at Columbia Basin Hospital. I have a question for you. So we currently do TCM calls, been through your class, all that sort of thing, and we call all of our inpatients, and then our clinic, CBFM, they call their own patients, but the nurse over there calls. So I am concerned that that we make a TCM call to a Confluence patient that's been an inpatient, and we provide the non-face-to-face services, and then in 6 days, you guys do the face-to-face provider. At that point, or your provider does the face-to-face, at that point, can your provider bill for that after we've done 2/3 of the work?
No, ma'am.
Okay?
Has to be
Okay.
done by our employees or people we contract to. Has to be someone, it has to be done by someone that the physician has the right to
Oversee or give
oversee.
direction.
Right, so if we had a contract with a case management service, that would work, but yeah,
Okay.
in the situation you gave, no.
Okay, so for us, for example, the only ones we would be able to bill for then would be our CBFM patients, if they were Primera or one of those, not anyone else's patients that we do TCM calls and see.
Would be correct, right?
That would be correct.
Okay,
Why would you not bill the Medicare patients?
well, we would, sorry. Well, we're a rural health clinic. I mean, we would bill them.
Right, look at your all-inclusive rate, yeah.
Right, right.
I also think it's important to go ahead and bill these codes to Medicare for data collection.
Right,
Even
right.
though you're only getting paid the all-inclusive rate.
Okay.
And this is Joel. Just keep in mind too, currently Confluence, we'll call like all patients, whether or not their primary care is Confluence Health or otherwise, discharged from Central Washington Hospital. But the only other people we call are discharged from Mid-Valley Hospital, but only if they have a Confluence Health primary care and they have a follow-up with that primary care, and only if they're from Samaritan, the same scenario, if they have a Confluence Health PCP and they have a follow-up with that PCP. Although there is one caveat, I think the ortho department in Wenatchee is
Oncology.
is working with Samaritan with the knees up there. They're doing the discharge call for knees up there.
But those you can't bill TCM.
Correct. They're doing that as a service for the service for ortho and kind of a program they're working on. But
I didn't touch on all the rules. Do you guys want me to touch on all the rules at all? So if a patient has surgery, the provider who did the surgery cannot bill TCM. If the provider sees a patient for TCM and does a procedure on the same day that has a 10 or 90-day global, they cannot bill both. Because TCM cannot be billed during a global period for a service that same provider did. Is that clear as mud? So an example is I had an internal medicine doc recently do a TCM visit, but he also did an excision removal that had a 10-day global, and because of that, it hit a CCI edit. And so we had to bill it as an E&M instead of a TCM visit because of it being in a global period in the same provider. Our oncologists are starting to bill these visits because a lot of times the oncology patients are getting all of their care from the oncologist when they're in the throes of treatment.
and generally from Central Washington Hospital, when we call a surgical patient, we're kind of trying to call everybody, and we just bill for the ones that qualify for the billing. But so while we might call a surgical patient if they had a simple procedure from the hospital, we wouldn't bill for it because if they're in that global period. Where you could bill for it was if they had a surgery and they had some kind of complications when they were in there and they were seeing their primary care provider for a hospital follow-up. Then in that case, you could bill for a TCM.
If you're billing chronic care management, you cannot bill chronic care management and TCM in the same month.
And there is some other oversight. If you follow the link kind of at the end of the PowerPoint, it's a link to the CMS guidelines for TCM, the newest version, and it does include in there some instances when you can't.
Yeah, if you're billing hospice care plan oversight, you cannot bill TCM. So basically, if you're doing any other care plan type stuff, because TCM is considered a care plan service, you can't bill those in the same month.
And I think that also includes home health oversight and end-stage renal.
Yes.
Can I ask, going back to some of the old slides, maybe some of the partners can jump in. Kobe, you were saying you hold all documents or charges for 30 days.
Yes.
And that was slightly a carryover from the old rules and regulations. I'm curious on the phone, do other partners hold their charges for 30 days, or do they do it differently? And could they share the pros and cons to that format? And I'm going to pick on Tracy or Shoshana, since Vicki just spoke up.
This is Tracy. I'm actually going to defer that to Shauna, since she's our guru of that.
Sorry, can you repeat the question? I was answering somebody who walked into the office.
No problem. Do you guys hold your guys' codes for 30 days, or do you bill them right at the time of visit? And have you seen any issues associated with that? So right now on the PowerPoint is the TCM Confluence Health Coder workflow, and so they hold all their coding for 30 days to ensure that it's, I may say this wrong, to ensure that all the things they're going to bill is accurate. But by technicality, you don't have to do that anymore. So I was curious on how you guys do it and the pros and cons you found out of that.
I think we've actually done it both ways, because I didn't realize we were supposed to hold them for 30 days. But I'm not sure if we've seen anything repercussions from that I'd have to ask the billing department that.
So
and I'm not the only coder for the clinic, so
So I should confirm you don't have to do it that way.
Right.
That's not what I'm saying. I was just curious how other organizations are doing it and what they have found effective.
And we actually don't have a whole lot, but the ones I have done, because I personally did not know we were supposed to hold them for 30 days, so we were doing them as they were coming across our desk, but we're usually about a week out from the date of service for coding.
Okay, but there's no longer a requirement to hold them for 30 days. That was at the very beginning. We just chose to continue to do that here because of the touch it once scenario, to have the coder just hold it, so that way if the patient expires or gets readmitted, we don't have to then have a follow-up person touch it to submit a corrected claim. The coder's just easier to have the coder just hold it, and then we make sure it's correct before it goes out the door. Because the service isn't worth as much once we have to have it corrected, because then there's manpower out used to refund, if we've already been paid for the visit, then we have to refund it and submit a new claim and send documentation.
Yeah, no, that makes sense. That's something that I will have to look into.
And this is, again, just go ahead.
At Cooley Medical Center, we had not been holding ours because we didn't know about it and won't continue. But a con for us, even if we knew about it, would be that it drives our days to final build up. That money sits on our AR, and honestly, in the Medicare FIS system, it's pretty simple to correct something like this. So probably would have supposed to push them through anyways.
And again, you do not have to hold them.
Right.
I just was curious to come back and hear how other people were doing it and benefits and negatives of each direction. I'm curious. I think, I'm sorry, I'm asking all of you guys the questions. But in regards to that, I want to get this right, HCAP scores, in regards to rural health clinic billing, did I say that right? Or HCCP?
The HCC. The severity rated scores?
Does anyone have questions around that, or do you guys all currently utilize PCM to help enhance your severity score rating? Or does anyone? I'm not getting a lot of response for that. Do you guys, Kobe, can you go through how you've been able to use TCM to do that, or do you feel like TCM can enhance the severity score?
I feel like it can, because as I said earlier, some of these patients are patients that don't come in for regular follow-up. They end up in the ER acutely ill and admitted, and so getting them in for this TCM visit, you know, even though their, you know, claims are submitted from the inpatient side, it's an opportunity to get them in with their primary care doc and get those codes documented and submitted, as well as anything new that the patient has been diagnosed with during their stay. And even though, the Medicare Advantage plans are the big ones that pay us based on severity. I mean, everything with them is based on the severity scores. With our fee-for-service Medicare in the rural health settings, our all-inclusive rate is not directly affected by severity rating. However, other payments that we get from Medicare, from value-based purchasing payments, those are directly affected by severity-rated scores. So even with fee-for-service, it does make a difference getting those HCC scores documented and submitted.
Because they'll get more money next year per patient, right?
Well, not with
Per that
fee-for-service. It's another payment that we get from Medicare, and part of that equation is the severity scores.
I had somebody had submitted, I think, a question about SDOH or social determinants of health, and how that might, if there was any, I think it was if there was any way it could be billed within TCM or any relation to TCM and billing, but my understanding is not really at this time, and we were kind of talking it over earlier, and some of those codes might pertain more to ER and inpatient side, although maybe at some point more on the outpatient side too, but for billing purposes, for TCM reimbursement, it doesn't seem, unless they increase those HCC scores somehow, which
Yeah, I don't.
Kobe's shaking her head no. It really wouldn't have much to do with the TCM billing at this time. It doesn't look like.
Are there any, based on some of these conversations, are there any questions from anyone on the phone that they'd like to ask? I know I feel like this still doesn't completely solve a large number of our billing issues with TCM, knowing that it's really, for the rural health clinics, it's really just the private payers that reimburse it directly, and then Medicare that you can indirectly infuse it into your all-inclusive rate. So I know this training isn't really a complete solution in that regards, but I think the goal really is to just get an understanding and see what people have questions, and if there's any additional support that could be provided, either by Kobe and Joel by answering some questions, or even across partners if there's a certain process. People want to know how other people are doing it. I think the benefit to is just even asking the question and having everyone jump in and share their experiences.
And I think at some point too down the road, we'll all have to kind of come together to see as more facilities kind of expand, like if Samaritan Hospital starts doing their own discharge calls, or Mid-Valley Hospital starts doing their own, at what point, we just make a decision who's going to call who, so we don't double up on calls, because clearly only one organization is going to be able to bill for it. But the goal would be the patient's called. We just have to figure out who that would be. So that will be, I guess, more to be revealed down the road. I know we've talked, or at least Lori, I think I've talked to Lori Berkman about it a little bit in the past from NCACH, but that will have to we'll have to iron that out later.
All right, any final questions around billing and coding? If none, these slides will be shared and this will be posted online on the portal. So I know if you're interested in what insurance is, you'll have access to that do reimburse, you have access to these slides. I'm going to openly admit this issue has been raised to the Healthcare Authority multiple times by multiple ACHs. And I don't see any immediate future solution for Medicaid doing the reimbursement of TCM, but you never know. Other than that, feel free to email any kind of questions you have, and I will share it with the group, and people are able to provide responses or answers. I'll let Kobe and Joel provide any input they have. But again, I think a lot of the fact, especially since a number of the people are following our rural health clinics and so have a very similar setup, it would be beneficial to ask those questions amongst each other and share some of those responses amongst the group, because you guys are in a little bit more of a similar situation than you might be with Confluence, who has rural health clinics but also has a slew of other things in regards to clinic and hospital stuff that they are taking into consideration in this work. And Joel had one last thing.
I was just going to mention, definitely click on that link. You can also Google it, but the link towards the end with the CMS information sheet, it is actually gives pretty helpful information. Some of it's very specific, and some of it is kind of vaguely written, as some of the CMS guidelines are. But I refer to this fact sheet pretty often, actually. But yeah, it's the newest one. It's January 2019, so it's the most up-to-date one right now.
All right. Well, we have a little bit of a quiet group today, so thank you guys for joining. And again, if you have any final questions, shoot me an email. I'll send this all out to the group.
Thank you.
Thank you, John. Bye.
Thank you all.
Thanks.
Thank you.